Welcome to this video focusing on gastrointestinal dysfunction. We will explore various aspects of the digestive system, from fundamental concepts like fluid balance to specific conditions encountered in clinical practice. If today is your first day here, please don't forget to subscribe, like, and share. Also, leave your comments under the comment section if you have any questions or topics you want me to talk about. All right, everyone, welcome to GI dysfunction, a topic that goes way beyond just bellyaches. We're going to look at how the gut impacts hydration, electrolytes, nutrition, and overall wellness. Whether it's a baby with projectile vomiting or a teenager with Crohn's, this system tells us a lot when it's out of balance. Let's begin by reviewing the distribution of body fluids. Total body water is divided into intracellular fluid within the cells and extracellular fluid outside the cells. Extracellular fluid includes interstitial fluid and plasma. Fluid requirements can increase in conditions like radiant warmer use or shock, while they may decrease in situations such as heart failure or increased intracranial pressure. Total body water is split between fluid inside the cells, intracellular, and outside the cells, extracellular, like plasma and interstitial fluid. Kids, especially infants, have more extracellular fluid, which makes them more vulnerable to dehydration. And things like radiant warmers in NICU or fever increase their fluid needs. Accurate measurement of intake and output is fundamental in assessing fluid balance. This includes quantifying urine and stool output, vomitus, and estimating fluid loss from sweating. Monitoring vital signs, skin turgor, mucous membranes, and body weight provides further clues. In infants, fontanelle assessment is key, while sensory alterations can indicate fluid imbalances in older children. You can't manage what you don't measure. Record everything: what goes in, fluids, feeds, and what comes out, urine, stool, vomit. For babies, weigh diapers. For older kids, track output. Don't forget other clues: sunken fontanelles, dry mouth, irritability, and weight loss. Tonicity refers to the number of solutes in a solution compared with the bloodstream. Isotonic solutions like 0.9% sodium chloride have the same tonicity as blood. Hypotonic solutions such as 0.45% sodium chloride have less tonicity, causing water to shift into cells. Hypertonic solutions like 3% sodium chloride or IV mannitol have greater tonicity, drawing water out of cells. Isotonic, like normal saline, stays in the vessels. Hypotonic, like half normal saline, shifts water into cells. Hypertonic, like 3% saline, pulls water out of cells. We use each based on what the body needs. So understanding this helps you pick the right fluid. Extracellular fluid volume is closely linked to sodium and water balance. Volume deficit or extracellular contraction can result from water loss leading to hypernatremia, sodium loss leading to hyponatremia, or isotonic loss with normal sodium. Volume excess or extracellular expansion can result from water excess causing hyponatremia, sodium excess causing hypernatremia, or isotonic excess with normal sodium levels. If a child is losing just water, sodium rises due as hypernatremia. If they lose just sodium, water stays due to hyponatremia. Isotonic loss? Think vomiting, diarrhea. Knowing this helps you interpret labs and rehydrate correctly. The renin-angiotensin-aldosterone system, or RAS, is a critical regulator of blood pressure and fluid balance. When the kidneys sense decreased circulation or blood pressure, they release renin. This triggers a cascade involving angiotensinogen, angiotensin I, and angiotensin II. Angiotensin II stimulates aldosterone release, promoting sodium and water reabsorption, and causes vasoconstriction, ultimately increasing blood volume and pressure. Think of RAS like your body's backup plan. Low blood flow leads to renin release, which leads to angiotensin II, which then leads to vasoconstriction, plus aldosterone equals to sodium and water reabsorption. Then BP goes up. It's why kids with dehydration often compensate well until they crash. Dehydration is a state characterized by a diminished water volume in the body. This often leads to increased sodium concentration if primarily water is lost. It results in a deficit of intracellular fluid, causing cells to shrink, and a decreased amount of water in the extracellular fluid. Recognizing the signs and symptoms is vital for prompt intervention. First thing you'll often notice, weight loss. Then look for dry lips, sunken eyes, low urine output. Severe cases show lethargy and tachycardia. This is an emergency, especially in infants. Edema refers to the accumulation of excess fluid in the interstitial spaces. It can be localized, such as peripheral edema in the limbs, or generalized, like ascites or pulmonary edema. Assessment often includes measuring abdominal girth in cases of ascites. Therapeutic management focuses on treating the underlying problem causing the fluid imbalance. You'll see swelling in the belly, ascites, hands, or face. It's not just a kidney thing. Liver failure, protein loss, or even heart problems can cause it. For ascites, track abdominal girth daily. Constipation is a common issue across different age groups. In the newborn period, failure to pass the first meconium within 24 to 36 hours can be significant. In infancy, it's often related to diet, being less common with breastfeeding. In childhood, it can be environmental or related to attempts to withhold stool. Therapeutic management aims to promote regular bowel movements, often involving increased fiber intake. Newborn didn't pass meconium in the first day or so. That's a red flag. With infants, formula and solid foods can change bowel habits. In toddlers, stool withholding is common, especially during potty training. Encourage fiber, hydration, and routine. If you hear, "My kid poops once a week," that's not normal. Diarrhea, frequently transmitted via the fecal-oral route, involves altered intestinal motility and absorption. Diagnostic evaluation includes a thorough history, inquiring about travel or contact with animals. Therapeutic management focuses on assessing fluid and electrolyte status and providing rehydration. Care is often managed at home, with emphasis on perianal skincare and prevention strategies. Diarrhea isn't just an inconvenience, it's a fluid and electrolyte nightmare, especially for young kids. Ask about recent travel, sick contacts, or animal exposure. Assess hydration and don't forget the bum. Frequent loose stools, diaper rash city. Rehydration and good skin care are essential. Hirschsprung's disease is a congenital anomaly where a segment of the colon lacks ganglion cells, typically involving the rectum and proximal colon. This aganglionic segment cannot relax, leading to an accumulation of stool and distension of the bowel proximal to the affected area. A key feature is the failure of the internal anal sphincter to relax, and there is a potential risk for enterocolitis. Without those ganglion cells, the bowel can't relax to let stool pass, leading to megacolon. Signs include delayed meconium, chronic constipation, and ribbon-like stools. Risk of enterocolitis is real, so early detection is critical. Treatment for Hirschsprung's disease primarily involves surgery. This is often performed in two stages. First, a temporary ostomy is created to divert stool and allow the bowel to decompress and heal. The second stage is a pull-through procedure, where the aganglionic segment is removed and the healthy bowel is connected to the anus. Nursing care involves comprehensive preoperative and postoperative management, as well as discharge planning. First, a temporary ostomy lets the rest of the bowel recover. Then the surgeon pulls through healthy bowel to the anus. Nurses prep families on stomach care, infection signs, and long-term bowel management. It's a marathon, not a sprint. Disorders of motility involve abnormal movement of contents through the digestive tract. Gastroesophageal reflux, or GER, is a common example involving the transfer of gastric contents into the esophagus. While GER occurs in everyone, its frequency and persistency can be abnormal, potentially leading to GERD disease. It's important to note that GERD can occur without GERD disease, and GERD disease can occur without visible regurgitation. GERD is a top example, stomach contents coming back up the esophagus. It's normal for babies to spit up, but if it's persistent or causes pain, that's GERD. Nursing care focuses on positioning, feed size, and sometimes meds. Gastroesophageal reflux is the movement of stomach contents back into the esophagus. This is a normal physiological process that happens occasionally in everyone. However, when it occurs frequently or persistently, it can become problematic. The presence of GER does not automatically mean a person has GERD disease, which involves symptoms or complications resulting from the reflux. Let's clear this up. Reflux does not equal to reflux disease. Babies spit up all the time, no biggie if they're gaining weight. But when reflux causes pain, poor growth, or respiratory issues, that's GERD. Thickened feeds, smaller volumes, upright positioning can work wonders. Gastroschisis is a congenital defect where the abdominal wall fails to close properly, resulting in the bowel being located outside the body, usually near the umbilicus. It is often associated with genetic factors and can be diagnosed prenatally via ultrasound. A planned delivery is crucial if the condition is known. Survival requires surgery soon after birth, often involving a staged repair over several days or weeks to gradually return the bowel to the abdominal cavity. Picture this. The baby is born with bowel hanging out next to the umbilical cord. It's not in a sac like omphalocele, it's exposed. Wrap in sterile saline dressings and plastic before surgery. These babies often need a silo and staged repairs. Irritable bowel syndrome is classified as a functional gastrointestinal disorder. It is characterized by symptoms such as alternating diarrhea and constipation, flatulence, and bloating. Care management for IBS involves providing support to the patient and educating them about the condition, symptom triggers, and strategies for managing their symptoms. It's more common in teens and young adults. No visible damage in the gut, but symptoms can be disabling. Triggers, stress, certain foods, hormonal changes. Teach kids how to track symptoms, manage stress, and modify diet. Acute appendicitis is the inflammation of the vermiform appendix. Understanding its etiology and pathophysiology is key to diagnosis. Diagnostic evaluation often includes assessing for pain at McBurney point. Therapeutic management typically involves surgical removal of the appendix. Complications like a ruptured appendix can affect the prognosis. Post-operative care is a significant part of nursing management. Watch for right lower quadrant pain, especially McBurney's point. Fever, nausea, rebound tenderness, wire, red flags. Rupture risk goes up if not treated quickly. Surgery is usually the fix. Post-op, watch for infection and support pain control. Inflammatory bowel disease encompasses conditions like ulcerative colitis and Crohn's disease. These involve chronic inflammation of the gastrointestinal tract. Diagnostic evaluation helps differentiate between the types. Therapeutic management includes medical treatments, nutritional support, and sometimes surgical intervention, all impacting the prognosis. Interprofessional care management is essential, including providing emotional support due to the chronic nature of these conditions. These aren't your typical belly bugs. Crohn's can affect anywhere mouth to anus. UC sticks to the colon. Expect weight loss, diarrhea, and anemia. Treatment: immunosuppressants, steroids, and sometimes surgery. Support is key. These kids can feel isolated. Cleft lip and cleft palate are facial malformations that develop during embryonic stages. They can occur separately or together. The etiology is often multifactorial, involving a combination of genetic and environmental factors. Diagnostic evaluation is typically based on physical examination at birth, although prenatal diagnosis is sometimes possible. Babies can't form suction well, so feeding is a big issue. Use special bottles and hold upright. Surgery usually fixes cleft lip first, 2-3 months, and cleft palate later, 6 to 12 months. Long term, speech therapy, dental work, and emotional support. Severity varies. Some kids have a tiny notch, others a wide gap. Early intervention helps reduce complications. Nurses play a key role in post-op care, protect the surgical site, prevent infection, and guide families through this journey. These conditions present with varying degrees of severity, affecting the lip, the palate, or both. The specific presentation dictates the complexity of feeding challenges and the surgical approach required for repair. Esophageal atresia is a congenital condition where the esophagus fails to form as a continuous passage. Tracheoesophageal fistula involves an abnormal connection between the trachea and the esophagus. These can occur separately or more commonly in combination. Understanding the pathophysiology is crucial for diagnostic evaluation and therapeutic management, which significantly impacts prognosis. This is one of those conditions that's caught right after birth. The baby can't swallow properly, starts choking on their first feed, or has frothy secretions. TEF means food or saliva can end up in the lungs. Bad news, it's a surgical emergency. Nurses play a big role in suctioning and keeping that airway safe before surgery. Therapeutic management for esophageal atresia and tracheoesophageal fistula primarily involves surgical repair. Prognosis depends on the specific type of defect and associated anomalies. Care management requires specialized skills, including meticulous preoperative preparation, intensive postoperative care focusing on respiratory and nutritional support, and managing potential long-term complications or special problems. Pre-op, we're suctioning frequently and keeping the baby NPO. Post-op, we're watching for aspiration, stricture, or leaks. Feeding is slowly introduced. Long-term, these kids might need support for swallowing or reflux. Hypertrophic pyloric stenosis involves a thickening and constriction of the pyloric sphincter, obstructing the outlet of the stomach. Understanding the pathophysiology helps explain the characteristic projectile vomiting. Diagnostic evaluation often includes ultrasound. Therapeutic management is surgical, involving a pyloromyotomy to relieve the obstruction. Prognosis is excellent after successful surgery. Care management includes careful preoperative preparation and postoperative feeding advancement. Classic sign: projectile vomiting, but the baby still acts hungry. The thickened muscle prevents stomach contents from moving to the intestines. Ultrasound confirms it. Surgery is simple, pyloromyotomy, and recovery is fast. Nurses prep for dehydration correction and help parents navigate post-op feeds. Intussusception is a condition where one segment of the intestine telescopes into an adjacent segment. It is a common cause of intestinal obstruction in young children. While occasionally associated with intestinal lesions, the cause is often unknown. This telescoping can compromise blood supply to the affected bowel segment, requiring prompt diagnosis and intervention. This causes sudden abdominal pain, sausage shaped mass, and current jelly stools. It's dramatic and comes out of nowhere. An air or contrast enema can often reduce it. If not, surgery is needed. Monitor closely for recurrence. Malrotation is an abnormal rotation of the intestine during embryonic development, leaving it susceptible to twisting. Volvulus is the twisting of the intestine around itself, which can severely compromise blood supply, leading to ischemia and necrosis. Diagnostic evaluation is critical for timely intervention. Therapeutic management involves surgical correction, and care management focuses on recognizing signs of obstruction and ischemia. Volvulus is an emergency. It can kill bowel tissue. Symptoms include bilious vomiting, green E, bad, abdominal distension, and pain. Immediate surgery is needed to prevent necrosis. Nurses look for red flags and prep for surgical care. Celiac disease, also known as gluten-sensitive enteropathy or celiac sprue, is a chronic autoimmune disorder triggered by gluten ingestion. Key characteristics include steatorrhea, general malnutrition due to malabsorption, abdominal distension, and secondary vitamin deficiencies. Gluten damages the small intestine, flattening villi, which leads to malabsorption. Classic signs: fatty stools, bloating, and growth delays. Diagnosis: Jacques biopsy and blood tests. The only fix: lifelong gluten-free diet. Nurses help families read labels, plan meals, and prevent accidental exposure. The pathophysiology of celiac disease involves villous atrophy in the small bowel, primarily in individuals with a genetic predisposition. Diagnostic evaluation includes serological tests and intestinal biopsy. Therapeutic management is primarily dietary, requiring strict adherence to a low gluten or gluten-free diet for life. Prognosis is excellent with dietary compliance, but care management involves ongoing education and support to maintain the diet and monitor for complications. This isn't just avoiding bread, it's reading every label for hidden gluten. Education is constant. Kids can live totally normal lives but need support to handle diet changes, especially at school and social events. Growth and labs are monitored regularly. Thank you for watching. Please do not forget to subscribe, like, and share.